Welcome to Chiropractic Science, where you get to hear interviews with leading chiropractic researchers from around the world. Hear about chiropractic research from the authors in plain English, not through the media nor a middleman. My name is Dr. Dean Smith, and I am the host of Chiropractic Science. I am a senior clinical faculty member in the Department of Kinesiology and Health at Miami University, and I'm also a chiropractor in Eaton, Ohio. My research interests relate to understanding how chiropractic affects motor control and human performance. Before we get to the interview with Dr. Andreas Eklund, I wanted to thank all of you who have subscribed to Chiropractic Science, and I'm especially appreciative to all of you who have contributed 5-star reviews on iTunes. iTunes reviews really help others find out about chiropractic science. So if you like the show, please take a second and write a review. It will support chiropractors everywhere. I'd like to share a review on iTunes from Dr. Dirk Jacobs. He says, "Thank you and well done, Dr. Dean Smith, for creating this podcast series. It is wonderful to have access to the thoughts and minds of some of the greatest researchers in the world. I am recommending this series to all of my colleagues. I look forward with anticipation to the coming podcasts and to learning something new from the world of research." Well, thank you, Dr. Jacobs, for your review. I look forward to sharing your clever and flattering iTunes review in a future podcast episode. Please consider making a contribution to chiropractic science to keep these podcasts going. You can do so on our website either by making a donation or by purchasing the evidence-based patient education slides presentation. We're also on social media, including Facebook and Instagram, so please connect with us there. All right, on to the podcast. Well, let's get on to the interview with Dr. Andreas Eklund. I am really excited that in this interview, we'll discuss topics such as the effect and cost-effectiveness of chiropractic maintenance care in a population with recurrent and persistent low back pain, the demarcation of a low back pain episode, psychological and behavioral characteristics of chiropractic patients compared to other primary care patients, and predictive properties of the West Haven Yale Multidimensional Pain Inventory among patients with recurrent and persistent low back pain receiving chiropractic care. Andreas Eklund, DC PhD, graduated from the Anglo-European Chiropractic College in 2002 and was in full-time chiropractic practice up until 2012 when he enrolled in the PhD program at Karolinska Institute. In 2015, he was a co-founder of a multidisciplinary rehab unit, which today employs 23 persons, working as an integrated team of health professionals, chiropractors, physiotherapists, occupational therapists, dietitians, and massage therapists. He earned his PhD degree in 2016, and the title of his thesis was Recurrent and Persistent Low Back Pain Course and Prevention. He currently works as a postdoc at Karolinska Institute, along with his clinical duties. At the moment, he also serves as the chair of the scientific committee of the Swedish Chiropractic Association. His research has mainly focused on psychological factors in chiropractic populations, maintenance care, and he has a particular interest in clinical outcome research applicable to the practicing chiropractor. In 2016, he was awarded Chiropractor of the Year by the Swedish Chiropractic Association and won the EAC Gene Robert Research Award First Prize. He is currently one of the 13 fellows of the Chiropractic Academy of Research Leadership, or CARL. Dr. Eklund, it's an honor to have you on the Chiropractic Science podcast.
Well, thank you. It's a great honor to be here.
Great. So we've got a lot of interesting things to talk about. You've been busy these last few years, and I just want to probe you for all the interesting tidbits you've been doing. So first thing is, and I ask this of everyone just because I think it's interesting to get a background, how did you become interested in becoming a chiropractor?
Well, I'd hope I'd be able to give you a miraculous story, but I don't really have one like that. I was interested in the health field. I had an idea about wanting to work with healthcare in some aspect, and as going into university, I was very interested in chemistry. So I started a degree in pharmaceutical chemistry and was moving on to a world within the probably pharmaceutical industry. And during that period, I worked extra at pharmaceutical companies within the production and clinical research departments, and kind of started realizing that I really wanted to be closer to the end product, to the patients, and that the pharmaceutical industry was too much of an industry for me. And then during that time period, I met a group of chiropractors that were very enthusiastic about their job, and I ended up going to visit them in their clinics, and had an idea that, I think this is something I could do, and it looks like a lot of fun. So quite quickly, I decided to change paths and sold my sofa, moved out of the apartment, and managed to get late into the program at the ACC. And from there on, it's history.
Excellent. I like the sofa part too. Now, you had been in practice for quite a few years, about 10 years before going back to pursue your PhD. Can you tell us a little bit about your practice of chiropractic, and then why you wanted to get back to the PhD?
Yeah. So I when I graduated from college, I really had no particular research interest. My absolute focus was to see patients and become a good chiropractor and develop the skills necessary. And as I went through my first few years, I started realizing there were a lot more questions than answers in practice, and I was struggling with how to see and comprehend what we do as chiropractors. And me and my colleagues, we were really interested in working on getting a system where we could evaluate patients and have clinical outcome measures that could show that we had a good effectiveness. But soon realized that it was much more difficult than I thought, and realized I didn't have the tools or the skills necessary to really understand the results that we would get from the questionnaires and how to use them, and so I got more and more interested in research. Started reading research books, a lot more papers, and then I got involved in a research-based network of chiropractors that was headed by a professor from Denmark, Charlotte Leboeuf Ide. And the idea behind this practice and network was that we were to do good research in a clinical environment, and clinicians got the chance to actually be exposed to the research process. All the way from planning projects to formulating hypotheses and conducting the experiments and analyzing the data and being part of the actual production of the manuscript. So it was a great way as a clinicians to get involved with research without having to invest a whole lot of time. And during that process, I was involved in 2 publications and got more and more drawn to the scientific process or the research process, and started realizing this is the path I want to take. And then there was a PhD position available at Karolinska Institute, looking at maintenance care as the main focus, and I jumped on that, and that's it from that on.
Well, that's great. And that is such an important issue. We often see patients that feel like they do better after continued care. And I'm glad that you are taking up the lead to look at this issue. And we're certainly going to dive into that later. But before we get too far, I don't know that too many people are familiar with the Carl Fellows yet, but you've been involved in the Chiropractic Academy of Research Leadership, and you're one of the fellows. Could you tell us about the Carl Fellows?
Sure. It's a very interesting program that I became part of this year. And it's a partnership with the World Federation of Chiropractic and the European Center for Chiropractic Research Excellence, ECRA, with the aim of fostering or mentoring early career researchers to become the future leaders of the field of the research field of chiropractic. And the idea is that by picking individuals who have made contributions in the field of chiropractic research and from different disciplines, and putting them together in a network would allow them to develop interprofessional relationships in the future and build research capacity for the profession, but also in the short term make use of each other's experiences, talents, skills, and do joint projects that would allow us to increase the research output from the chiropractic research community. And we have some great mentors, Jon Hartvigsen, of course, and John Adams from Australia, and of course Greg Korchuk. And the idea is that we meet once a year, and this year we were in Odense, Denmark. Next year we're going to Canada, and the third year we're going to Australia and meet up. So the idea behind these meetings is that we get an intense mentoring with workshops and lectures, as well as doing group work together, getting closer as a research network, and working on ideas on how we can publish and do research together. And it's a great program. It's a great group of people, very inspiring to be with, and very talented and interesting researchers. So I look out for what's coming from that program. I think we'll see some very interesting and great research.
Yeah, that's really exciting, and nothing makes me more happy than chiropractors getting together for a common purpose to promote research. So fantastic. All right. So what I'd like to do next, you've got several papers that you've published, including your thesis that you've published on the maintenance care. But let's talk about one paper that came out last year, and this was prevalence of 4 consecutive weeks free from pain and its applicability as a marker of a low back pain episode. And this was published in Chiropractic and Manual Therapies. Could you guide us through that paper?
Oh, absolutely. We've been very good at defining low back pain in terms of episodes, but we haven't been that good at defining what constitutes recovery, or the end of an episode, or the demarcation of the next one. So in a joint, effort, there was a group of researchers who came together and put together a consensus of how we defined a low back pain episode. And part of that consensus was defining recovery. And what they did is they said an episode needs to be pain in the lower back lasting for more than 24 hours, and preceded and followed by a period of at least 4 consecutive weeks without pain. So in Denmark, a group of researchers starting to look at this, and they said, well, let's look at the prevalence of this definition of this idea. And they started with a secondary care population, and they found that hardly anyone in the secondary care population reported 4 consecutive weeks without pain. They then repeated the experiment in general population, and found that it was very common to see that patients or individuals, because these weren't people seeking care, reported that almost everyone. So the idea behind this paper was to look at a primary care population and see what is the prevalence of this concept. And within our populations, can we see that there is a degree of dose response, that people with a previous history of more pain would have less of these episodes of 4 consecutive weeks without pain, and the ones with more than 30 days, less than 30 days the previous year would have more of these. So using SMS as our primary outcome measure, we followed 262 subjects for 6 months, and recorded SMS weekly to track their trajectory of pain. And we found that a little over half, 59% of the individuals reported one of these episodes. And that there was, like we hypothesized, a kind of a dose-response relationship to it. So these results it's the kind of the last piece of the puzzle that allows us to now look at this further in terms of clinical relevance and other aspects that are quantifying this with regards to health outcomes. So not a super interesting paper perhaps, but I think an important piece of information that will allow us to do good research in the future and perhaps develop this into an interesting clinical measurement as chiropractors. Just as we ask how long they've had their pain, we might also be wanting to know how long the episodes between their pain are, because that might be associated with a certain degree of clinical characteristics. So that is the next step, to look at that, what that holds, so to say.
Yeah, for sure. About 10 years ago, I remember reading a paper for the first time, and it went something like, back pain we typically think of is gone after 4 to 6 weeks. And then that was it. There wasn't any discussion of the trajectory of back pain or what back pain looked like after that. It was just assumed that it was all gone. And so I don't know about where you are overseas, but here it was the kind of thing where, they would stop care early or not pay for it at all because they figured, the back pain's going to be gone within a few weeks anyway. So why bother do anything about it? But so I'm really glad that you're doing this kind of work, and it's so needed.
Certainly, I think the trajectory research is very interesting. With my Ibn Aksi and my supervisor, she's done a lot of work on trajectories, looking at subgroups and clusters of individuals. And one of the main conclusions from that work is that it is highly recurrent, and the way we classically see episodes is it's not really a very good way of defining patients, but rather the individual trajectory for each patient is a better marker of the future than trying to classify them in consecutive episodes. So certainly we need to understand a lot more about how the trajectories are and what we can expect from our patients. So I think what you're saying is it's changing. It certainly is changing, that we're moving away from these defined episodes into more recurrent condition that rather than leads long-term type of management rather than a short-term treatment option.
Yeah, I think you hit the nail on the head. More long-term management, or at least thinking about long-term management, which we'll definitely get into the maintenance care paper coming up. The next paper I'd like to talk about is psychological and behavioral characteristics of chiropractic patients, and this was published in BMC Musculoskeletal Disorders. Can you guide us through that paper?
Oh, certainly. I think this is an interesting paper because there has been some research before that has looked at chiropractic patients and tried to define them in terms of characteristics. And much of them have described them as better off in terms of psychosocial class. They seem to have a different profile than other patients. So this study was really the first one, at least, that we've done in Sweden, where we really, from a comprehensive perspective, look at the psychological and behavioral profile and compared patients, chiropractic patients, to other populations, and trying to figure out how do we differ? Are we affected by pain differently? Is our group by any means different? So our hypothesis was that we had 4 samples that we wanted to compare. We had a group of patients from the primary care sector, a group of patients with a quite substantial amount of low back pain. They were screened with a screening tool, and they were considered at high risk of developing long-term sick leave due to their pain. So they were by no means a group that were pain-free. So we thought this group would be worse off in terms of how they would be affected by their pain compared to the chiropractic group. Then we had two other patient samples from the secondary care sector, from specialized spinal care units undergoing multidisciplinary rehab interventions. These were really severely affected patients and were thought to be quite far from the patients that we see as chiropractors in the clinic. And the main instrument that we used was an instrument called MPI, which is a short for West Haven Multidimensional Pain Inventory, which is a rather old instrument, but quite broad. It's an extensive instrument that looks at psychological and behavioral characteristics from a cognitive behavioral perspective in a quite broad sense. It's old, and today we have more modern instruments that are shorter and much more applicable in a clinical setting. This was more designed from a research perspective to look at a broad range of characteristics. And you can describe the instrument. There's a number of questions. The Swedish instrument has 36 questions that boils down into 8 scales, 5 psychological scales, which measures pain severity, interference, life control, affective distress, support, and then 3 behavioral dimensions, observing punishing responses, solicitous responses, and distracting responses. And this is really how the patient perceives that their environment is acting because of their pain. Are they punishing them for the pain? Are they helping them, or are they trying to distract them? And from these scales, 3 subgroups have been derived. So depending on how you score on those scales, you can be classified to either of 3 different subgroups: adaptive copers, interpersonally distressed, or dysfunctional. The adaptive copers are the good group, with low pain severity, low interference, low distress, high activity level, high perception of control. Patients that we normally would consider probably chiropractic patients, or a lot of people would. Then we have the interpersonally distressed, who has in particular problems with the dysfunctional behaviors, with low social support, low levels of solicitous responses, and high scores on punishing responses. And then the third group, the dysfunctional, who has high pain severity, marked interference with everyday life due to pain, high affective distress, low perception of life control, low activity level. So these groups are different on the spectrum, and the ID and dysfunctional disc group have been shown in a number of publications that they're associated with a poorer outcome from treatments, higher risk of sick leave, from a wide variety of different chronic pain conditions. So they're valid and certainly interesting subgroups. So when we compared our patients, our hypothesis were that the chiropractic sample would be the one least affected by pain, but we found that it wasn't so. The other primary care sample was actually better off, and the chiropractic sample was worse off than there, and was kind of placed in the middle of those 2 secondary care samples and the other primary care sample. So it was a bit surprising to find that, and rather interesting that patients were so much affected by pain that we really didn't expect.
Yeah, why do you think that was? Why do you think the chiropractic sample was more affected by pain?
I don't have a good answer there, but it could be because of the way data was collected. The chiropractic patients, they were screened upon presentation at the clinic. So most of these, they came during a really acute episode. So it could very well have been that that colored the way they answered the actual questionnaires. The other patients, they were also under influence of pain when they scored their questionnaires, but it wasn't done in a clinical setting in that sense. On the other hand, the instrument doesn't really measure the acute experience. It measures the chronic experience, and so it shouldn't really affect that much. I think a better explanation would be that in particular patients in Sweden, they are not really used to paying for healthcare, because going to a physiotherapist or an MD, within the traditional healthcare system, you pay a very small amount as a patient. And the patients that do to end up seeing chiropractors, we do have chiropractors within the medical system, but the ones that were included in this trial, they were all clinics where patients paid for the fee themselves. So it could be that patients, because they were, this might have been a last resort, or they were paying because they were in substantial amount of pain and willing to pay that extra money to go see a private practitioner rather than the traditional healthcare system. So that could also be an explanation. But like I said, I'm not really sure.
Huh, that's really interesting. Let's talk about another interesting paper, and this is predicting the early clinical course of recurrent and persistent low back pain in a sample of chiropractic patients. This was published in BMC Musculoskeletal Disorders in 2016. And could you tell us about this paper?
Sure. So this was kind of a follow-up of the other paper where we did that comparison between the different samples. In this case, we used the same instrument, the MPI instrument, to see whether these subgroups could actually predict the short-term outcome from chiropractic treatment. And one of the things I think I have to say first is what we did is we measured the outcome at the fourth visit. And I guess some of the listeners might think that's really early to measure the outcome, but there's been quite a few studies in Scandinavia that's looked at treatment outcome, and it's pretty clear that we've been able to identify a subgroup of patients that respond really well to chiropractic care. Some already at the first visit, but most certainly people who respond well to treatment by the fourth visit are much more likely to have a better prognosis at 3 months, 6 months, and 12 months down the line. Now, this interesting finding about the outcome at the fourth visit we haven't really figured out what. We can't really decide this on the first visit based on clinical examination or outcome, other items in the case history. But it's a rather trial and error procedure. You try it and see if it works. And if they do, then you can give them an idea about the prognosis in the future. We know, for example, from Greg Korchak's research in Canada, that they've been able to demonstrate that certain individuals, they respond biomechanically much better than other patients. And they also report an improvement. Why it is, I don't think we know that either, and it's likely that these are the same patients. So this is the theory behind this article. We wanted to see perhaps the psychological profile could predict this. If the MPI instrument of these subgroups perhaps had any predictive ability to define who would have that definite improvement at the fourth visit. So that's why we chose this really short-term outcome in this trial. And interestingly, we found it didn't. There was really no difference either in pain intensity between the different subgroups or this reported outcome that we call subjective improvement, which was scored on a 5-step scale where they would have to respond to the last step of the scale, which is definitely improved. So this was really interesting. We couldn't really predict the outcome based on these psychological variables. And this has been supported with research from Denmark, where they've looked at the Startback questionnaire, which has an entire different construct structure. It looks at different aspects than the MPI instrument does. It's a much more modern instrument, and implementing that in chiropractic practice hasn't either improved effectiveness or added to the clinical procedure. So it is interesting that there is something about what we do that isn't as much affected by psychological factors that we perhaps previously thought.
Yeah, terrific. Or at least we haven't found the right variables yet to measure.
Absolutely. Or perhaps it's a different story altogether when you look at the long-term perspective. In particular, when we use this instrument that we've used, the MPI, which is a more of a chronic measure than acute differences. So perhaps when we look at this from a long-term perspective, we might see a completely different picture.
Yeah. Yeah. Very good. Very good. Well, the next paper that I want to talk about is hasn't been published yet, but it was one that you did with your doctoral thesis, and this was something that I think many chiropractors are going to be really excited to hear about. And this is the effect and cost effectiveness of chiropractic maintenance care in a population with recurrent and persistent low back pain. Can you lead us through that paper?
Oh, absolutely. This is one of my favorite papers. It's a project that I've lived with now for over 5 years, and it's not been a day that I haven't been thinking about it or working with it, or it's almost like a part of my physical being.
Great.
It's a wonderful study because it's based on a really ambitious research effort. I'd like to start off saying over the past 10 or so years, there's been a number of studies in the Scandinavian countries that have looked at maintenance care as a concept, trying to define what is it that we do during these visits, what is it, how do we schedule them, what is the frequency, content, what is the indications for care. So there's been a large effort just trying to map out what maintenance care is. And if you look on PubMed, it'll be under the maintenance care program as the first line in the title. So this is the culmination of all that work, really, that it was all put together into this randomized clinical trial where we try to, in the inclusion procedure, as much as possible, mimic the practice procedures of chiropractors, how they think about choosing patients and indications and trying to actually evaluate what is happening in clinical practice rather than implementing a procedure that's kind of new. So that's one of the things I love about this study. I think we've done a good job at actually, as close as we can, mimic reality. So what we did is we screened patients at the first visit for low back pain. And we wanted to include individuals who were had previous episodes, so they had a recurrent condition. We also wanted individuals who had a more severe condition, where they had more than 30 days the previous year. So individuals that fit that criteria and were screened for other diseases, of course, that didn't fit in, or pregnancy were excluded. Then we tracked these patients up until the fourth visit. Because one of the things we found in these interviews with the chiropractors before is that the patients that do become maintenance care patients are the ones that respond well. So it's very likely that these fast responders, or the one that at the fourth visit say that they are definitely improved, those are the ones most likely to become a maintenance care patient. And it also makes sense because that's at the moment the best way we have of defining who are the best responders to our treatment. So once they've then reached that fourth visit, they were screened for improvement, and the ones who were definitely improved, they then continued in the inclusion procedure. And the chiropractor treated them up until the point where they normally would have said, well, thank you very much, come back when you have your next episode, or now let's try to prevent this from reoccurring, let's put you on a maintenance care schedule. And that was the actual inclusion into the study. When the patient agreed to that, they were randomized to either maintenance care or the control group, which was subject to when they had pain. So they would get pain and they would call in and come back if they had another episode. And then we followed them for 12 months. We recorded their pain trajectories with SMS every week. We had a battery of tests in the during the inclusion procedure, where we looked at everything from psychological factors to activity limitations to self-rated health and a number of other descriptive data on them. And then we had a battery of follow-up questionnaire with a battery of follow-up instruments looking at some of the follow-up data on that we recorded at the first visit. And we managed to recruit 328 subjects in the trial, and 319 completed the trial. And we had about 99% data collection. So we only had less than 1% missing data on the SMS, which is in itself a remarkable achievement with a data set with that high quality. So in the for those of the listeners who've looked at the actual thesis, the data reported in there is a little bit different from the ones that we will report in the actual study when that comes out, because I had to break the data, start the data analysis early before all patients had gone through the study to be able to fit it into the thesis defense. So we had to impute or simulate answers for the ones that were missing. So the outcomes are a little bit different, but I'll talk about the outcomes in the thesis, and then when the paper will be published, people might see that there are small differences, but the conclusions are still similar to what we found, or the same actually that we found that have been reported in the thesis. Right. So what we found was that there was a clear difference. The chiropractic maintenance care group, they had less pain, and in the thesis we've written 19.3 days between the group, and they had that at only an additional 2 visits cost of a 2-month period of the 1 year period. So for 2 extra visits, they had almost a working month less with bothersome pain, which is an interesting finding itself. However, when you look at it from in the entire year, it's only half a day per week. So it's uncertain as to how much the patients actually would experience this difference, this improvement. It could very well be that what we're doing is we're reducing the episodes, so we're cutting the peaks, or actually making sure that they don't get new episodes. If that's the case, then certainly those 19.3 days will be clinically relevant. And we don't know that yet. There will be projects looking at how the groups differ in terms of this difference in pain, and also if this different psychological subgroups respond differently to the treatment. So based on that, we also did a cost effectiveness analysis where we looked at the cost associated with care from a patient perspective, and by multiplying the added extra visits with the cost of the treatment, travel to and from the clinic, and then looking at the mean hourly wage, we could then look at an estimated cost for the entire procedure. And we found that the cost was 164 euros extra for that group per year. And then we also did the similar analysis from a societal perspective, where we also not only put a monetary value on the actual cost of the treatment, but we include a monetary value of pain, because it's likely that the individuals who suffer from pain, well, they also probably suffer from production loss and presenteeism. We know that people with pain that are at work are less productive than individuals who are not. So we tried to model this and estimate it, because we had some data in the trial to do that. And with that estimation, the picture changes a lot, and there is actually a gain from using maintenance care. But that's a theoretical model that we use there. And in the paper, when we publish the cost effectiveness analysis, it's likely that we're going to redo that part of the analysis in a different way.
Wow, that's fascinating. The whole study is fascinating.
It's a complex study. I'm not sure I covered everything. Maybe you can ask me a few questions
I'd like
on areas that I missed.
Yeah, for sure. I'd like to ask you some questions. So the first one that I have is about the 19.3 days. And first I'll say to any patient who's had bothersome low back pain, if they get 19 less days of that a year, to me, that's pretty huge. I know you mentioned that if you consider that over a year period, it might be like a half a day a week. Did you run any analyses where you looked at how it specifically affected the trajectories of people? Like, in other words, would it knock them out of work for 2 or 3 days, and we kind of, the maintenance care affected that? Or do you have any sense of the trajectory of how it went for the individual patients?
Well, that's a paper that I'm working on currently, where we're looking at this very thing, the trajectory of the pain around the actual treatment visits, to see did the trajectory look different for the maintenance group, meaning that did they actually get treated before they had the peak pain, or was there no difference in terms of the timing? Because that was kind of the idea behind this concept, is that the timing, because when the data from what we do in the actual clinical encounter is very similar with the control and the intervention group. In fact, we do pretty much the same thing. The dialogue might be a little bit different, but the actual content of the treatment is similar. So we think it has to do with timing. So we're going to look at that in a future study, the timing of that, but also from the point of a survival analysis, of seeing, can we actually reduce the number of episodes of pain? Is it that the individuals get fewer episodes? So if you bear with me a year or so, or a few months at least, I think we'll have that in publication soon. So that will be a real interesting article that will answer many of these questions on particularly how relevant are these 19.3 days.
Yeah, for sure. And I'd love to have you back on at a future date to talk about some of these papers. So with what you've written on this, and let's just say, patient comes to you in your practice and asks you about a paper such as this, how would you explain it to a patient?
Well, I think one of the really important things to say is that we have a really specific sample of patients here. It's not everyone that comes into the clinic that we've been able to show that this is important. So it is for the individuals with recurrent pain. It is for the individuals who have a longer episode of pain previously. And it is certainly for the patients who respond well to chiropractic care. So, I mean, if you can kind of ask those 3 questions, really, have you had recurrent episodes? Have you had more than 30 days the previous year? And by the 4th visit, do they seem to be a fast responder? Someone who would answer, I am definitely improved by the 4th visit. Then certainly they are a candidate. And what you certainly can say is that in the published paper, the estimate dropped from 19.3 to 18.1. So about 20 days per year is what we can gain on average from the maintenance care protocol. As to whether that is important for that particular patient or not is really hard to say, but there is now some evidence to suggest that it is one strategy that can help us. We know that pretty much the only other strategy that is effective is exercise, and exercise isn't effective for everyone, and certainly it's not something that everyone can comply with. So if the individual does not do well with exercise, and exercise alone cannot prevent pain, then I think this should be considered as an option, as an additional option. Or if exercise is just not something the patients can comply with. And also one of the things we saw is there's a great variability. There's, for some individuals, the maintenance care seems to be very successful. It's very, very effective, and for some individuals, it's borderline. Because the confidence interval ranges from 4.9 to 33.6. So that there's a wide range there in which patients actually do respond to this. And it is a real possibility is that we have psychological subgroups within this group that might respond better or worse to treatment. So that's also a very interesting article that is coming in the future, looking at, can we say more about who are the best ones in this group based on some of the baseline data that we have the most suited patients for. But I would say for sure we have some evidence now to support this standard protocol of an interval between 1 to 3 months as a maintenance care program.
Yeah, that's really, really neat. And I'm glad you mentioned about exercise and some of the other variables, because those are all really important. And when it comes to evidence-based practice, of course, we'd like to obviously include the patient in that. That's one of the three legs typically of evidence-based practice. So if they have a preference maybe for chiropractic care, let's say, then that might play heavily into their mind as to one of the options that chiropractors give people to try to deal with these longer term effects in the episodes that they may be experiencing. So terrific stuff.
Certainly, and I think it's perhaps important to point out that if maintenance care is at the cost of the patient's self-efficacy, meaning that when you include them in a maintenance care program, they get more and more passive and rely more and more on passive care, then that's a very bad thing. So I think part of the maintenance care program has to be to support the patient in being active and perhaps being someone who inspires them to stay active and exercise and do the most of what they can do themselves, and then use the maintenance care as a supporting protocol rather than making them more passive. I think that's a really important point to make, actually.
Very good. Well, Dr. Eklund, one of the goals of this podcast is to motivate and assist practitioners and students to pursue research careers in chiropractic science. Could you offer any advice to aspiring chiropractors who may wish to become scientists?
Absolutely. I think for me, one of the most important aspects of being able to transition into a research career was that chance of being part of that research network. And I know there are a number of different research networks out there, and they all look very different. So I think it's down to what kind of environment you work in and how do you live and what are the chances there. But if you have the chance to become actively involved in research, either as a clinician recruiting patients or as part of a kind of a management group managing other clinicians doing research, which was what I did in my group, I think that's a great way not only to connect with researchers and kind of make a name for yourself, show them that you are interested and that you are reliable and that you are a candidate for it. I think that's a great way of getting into it. If that's not a possibility, getting in touch with researchers and trying to assist them in different projects is also a very good idea. And also, of course, applying for whatever PhD positions are out there. I think we shouldn't restrict ourselves only to research that pertains chiropractic only. At this point, we really need to build a strong research base with a large group of researchers that can collaborate and build innovative, strong research environments. And for that, we need people with different skill sets, different ideas, different experiences, different contact networks. So I think also you shouldn't be afraid of stretching outside of the chiropractic field and talking to researchers in other fields and see if you can get a foot in there, because that's kind of how we got into KI. We were the first chiropractors really to my supervisor Eben and then Cecilia Bergström were the first two chiropractors at KI, and they kind of paved the way for me to get into this. And we were very lucky to have a professor that had a really broad perspective and were willing to take a chance on Lieben initially and Cecilia and now me. So I think getting to know researchers is a good way. And if you can, participate in research networks, because that's really important to be part of collecting really good data.
Excellent. I really like the advice to try to expand your knowledge base. Try, not be afraid to do something new, because as a chiropractor with a different skill set, that is very attractive to working with other colleagues from different professions, but also within the profession, just to be able to contribute new knowledge, different knowledge that we haven't done. So I think that's absolutely fantastic advice. And I must say, I've really enjoyed our talk today, and I've learned quite a few new things. So I really appreciate you being on the podcast.
Well, thank you very much. It's been a great pleasure, and hope to perhaps be on it again in the future when I have something else to report.
Absolutely. Thanks very much.
Thank you.
I hope you've learned as much as I have about maintenance care, the Carl Fellows, and much, much more. Stay tuned for more episodes. If you have suggestions or comments about the show, please let me know.